Morning. It's my pleasure to be here in this glorious Memorial Day in the history of Egypt and to be the first presenter on that day. Actually, I'm presenting on the behalf of my colleague and friend Abdurrahman Salim, who unfortunately won't be with us today. But this is his presentation. I just have added a few slides to compare the trials of thrombolysis. DVT of the legs may be divided into the distal calf DVT, the proximal DVT, which involves the veins below the inguinal ligament, and the iliofemoral DVT. As we know, the complications of extensive DVT includes pulmonary embolism, post-thrombotic syndrome, and patients with iliofemoral DVT has an exceptionally high recurrence rate in comparison to more distal DVT. The massive iliofemoral DVT has enormous, can produce phlegmasia, serial dolens, which actually increase the risk of venous gangrene. As we know, the 40 to 60% of DVT patients who receive anticoagulation and compression therapy will develop post-thrombotic syndrome within a couple of years, and iliofemoral DVT patients had the most severe post-thrombotic syndrome morbidity. And from our experience, we know that removing or lysis of this kind of clot is much easier than trying to reopen this kind of occluded vessel. So you can imagine the removal of a clot in comparison to try to open this piece of collagen and fiber and fibrin. And we know that patients who will develop post-thrombotic syndrome will develop many complications in the future. And this has negative impact on mobility, functional capacity, work attendance, and other aspects of quality of life in different age groups. So just to be clear, our aim when we have a patient with acute iliofemoral DVT is to remove the thrombus. And the strategy that we have to adopt is to completely, or as good as we can, to completely remove the thrombus. And this actually will restore the venous patency, the valve function, the quality of life, and the risk of recurrence will be reduced. There is a lot of research suggested that catheter-directed thrombolysis has a benefit, especially in patients with iliofemoral DVT. The more residual thrombus at the end of the catheter-directed thrombolysis will lead to the worse quality of life. This also correlated with the objective measures of post-thrombotic syndrome. The greater the degree of lysis, the fewer symptoms of post-thrombotic syndrome will be observed in the future. And pharmacomechanical techniques have been shown to improve outcomes compared to the catheter-directed thrombolysis using the drip technique alone. The pharmacomechanical techniques shortened the treatment times, reduced doses of lytic agent, which obviously led to less bleeding tendency and less length of stay in the ICU and hospitals. There are many trials were done, and the randomized control trials that were actually comparing the conventional treatment to the thrombolysis with different techniques is the CAVEN trial, the ATTRACT trial, and the CAVE trial. And we'll go quickly through these trials. And just my aim here is just when we read these articles and the conclusion of the articles, this will lead us to a conclusion that's not necessarily the right conclusion. So just to know that CAVEN trial was done in 20 hospitals, and they included all the patients from 18 to 75 years of age and included only iliofemoral DVT. And they included patients who were presented to them within the first 21 days from symptoms. While the ATTRACT trial was similar to it, but was done in the States, the CAVEN was in Norway, and included almost the same age group of patients and included symptoms within 14 days. The CAVE trial was done in Netherlands and included more older patients and include patients up to 14 days of symptoms and 21 days to start the lysis. I will not go through all the details of these trials, but I just want to highlight that all of them adopted the Villalta score as the main primary outcome to assess the post-thrombotic syndrome, which seemed to be at the beginning a valid outcome. So they are similar as regard the exclusion criteria. One of the differences in these trials that actually the lytic agent in the CAVA trial was urokinase in comparison to alteplase in the other trials. And the ATTRACT trial was actually has a shorter duration of action because it was pharmacomechanical thrombolysis. The CAVA trial is the most recent one. A number of patients varies. The ATTRACT trial had more patients, but these patients were divided into two groups: femoropopliteal as half of the patients, and iliofemoral half, the other half. And the outcome, actually, if we'll go to the outcome, the patency showed the primary patency after thrombolysis was actually significant in favor of thrombolysis only in the CAVEN trial, according to the protocol. And the post-thrombotic syndrome as well was significantly different in favor of thrombolysis in the CAVEN trial. While in the ATTRACT and the CAVA trial, the post-thrombotic syndrome didn't reduce that much and was not statistically significant according to the primary outcome. But in comparison, the bleeding tendency was higher on all thrombolysis groups. So the CAVEN trial was the only trial that actually reduced the risk of post-thrombotic syndrome by 14.4%, and this increased to 28% in the 5 years follow-up analysis. And the number of patients needed to be treated to avoid one post-thrombotic syndrome was 7 patients in 2 years, and this actually dropped to 4 patients in 5 years. If we go for the 5 years analysis of the CAVEN trial, which was the only trial that showed the primary outcome was positive in favor of thrombolysis, in the 5 years follow-up, it showed that actually patients who were on anticoagulation still developed post-thrombotic syndrome even after 2 years in comparison to the patient who got thrombolysis. So we knew from before that usually the post-thrombotic syndrome will develop within the first 2 years, but still patients who get in conventional treatment can develop post-thrombotic syndrome after 2 years. But CAVEN didn't discuss or show reduction in the severity of post-thrombotic syndrome. They didn't assess the patency, the edema, or the improvement in quality of life. So the ATTRACT trial was a very well conducted study and included so many patients, but as Dr. Komorota said himself in his comments, that actually choosing the assessment of post-thrombotic syndrome using the Villalta score was a poor choice. And the reason for that actually when they assessed the patient with the Villalta score, it didn't show any significant difference between patients who develop post-thrombotic syndrome in the thrombolysis pharmacomechanical thrombolysis group in comparison to the anticoagulation group. But actually, if they will assess the patient with the venous clinical severity score, it was in favor of the pharmacomechanical severity, pharmacomechanical thrombolysis. And the patients, when they assessed the moderate and severe post-thrombotic syndrome, this was significantly different and in favor of pharmacomechanical thrombolysis. The same applies to the leg pain, the leg swelling within 10 days and 30 days. All of them were statistically significant in favor of thrombolysis. And the mean Villalta score in the ATTRACT study showed that moderate to severe post-thrombotic syndrome was less in the patients who got pharmacomechanical thrombolysis. So in general, the CAVEN trial was the only trial that achieved the primary outcome in the form of decreasing the post-thrombotic syndrome incidence and the patency of the veins in the follow-up, while the ATTRACT didn't show that, but showed that in the venous clinical severity score, and the CAVA didn't show that. And as the ATTRACT trial actually used the pharmacomechanical use of thrombolysis, this reduced the duration of infusion, and the volume of the material was injected per hour was higher, and the total dose was less. The major bleeding as well was less in the ATTRACT trial because of the duration of lysis. And as we can see here in the subgroup analysis of the ATTRACT trial, it was very clear that patients who benefited more from the thrombolysis were the younger patients who had a major risk of developing DVT in the future, and the patient who had severe symptoms to start with. So thrombolytic therapy could be pharmacological and could be pharmacomechanical. And the pharmacological could be systemic, and could be catheter directed, which is preferred because of the general effect of the systemic lysis and complications. There are different types of pharmacomechanical thrombolysis, including the endovascular mechanical thrombectomy, the angiojet, the ultrasound accelerated thrombolysis that was used in the CAVA trial, the ACUS, and the Trellis, which actually is withdrawn from the market now. One of the most important things which we have seen and was shown in the research and studied and actually was explained yesterday is the duration of the thrombus. And there is a big difference between the timing of the start of the patient's symptoms and the age of the thrombus, which is the main key factor to ensure lysis of the thrombus and achieving the primary outcome, which should be the clot removal. And as shown yesterday in one of the presentations, that actually MRV seems to be the best way to find out if the patient has an acute, subacute, or chronic DVT. And if we will treat acute or subacute DVT, the results will be much better than if we'll try to do thrombolysis in the chronic setting. And the contraindications were almost the same. The agents that are used now, the urokinase, the alteplase, the RTP is more present in Egypt. And the access is different. People are actually were adopting the popliteal vein cannulation in the trials in most of patients, but nowadays there is an increased tendency towards using the tibial veins to be able to thrombolyze the popliteal, femoral, and the iliofemoral segment in the same setting. So after getting access to the deep venous system, the multi-pore catheter is introduced through the thrombus. The loading dose is different according to the technique adopted, and the infusion rate is between 0.5 to 2 milligrams per hour according to the thrombus load. Venography should be done every 12 hours to 24 hours till complete clearance of the thrombus. And what is usually helpful in this setting is using IVUS, because it seems that venogram alone cannot really ensure the interventionalist or the surgeon that actually there is a complete removal of the clot, and if there is an indication to stent the patients or not. Then all the patients will be anticoagulated and then convert to the conventional treatment after the finish of lysis. This is one of the catheters that we use to infuse the thrombolytic agent. The catheter-directed thrombolysis without universal prophylactic IVC filter placement is safe and effective in treating acute DVT. Actually, none of the trial proved that actually placing IVC filter during thrombolysis will improve the outcome. The risk of developing symptomatic PE is most markedly increased in patients with previous silent PE and heart disease. So we will actually recommend selective rather than routine IVC filter insertion. So there are different devices to do the thrombolysis. The pharmacomechanical, one of them is the angiojet, and we heard about it yesterday in details. And when it comes to venous stent, as we have mentioned, it's very important after the complete removal of the clot, assessed by the venogram plus minus the IVUS, which is essential if present, if available, then the patient should be assessed if the patient needs a stent or not. And if the patient needs stenting, ideally dedicated venous stent should be used. 1 year patency is reported to be without stenting 53 to 75%, while actually it increases to 54 to 89 if stent was placed on the proper site. I will not go through the complication, but I just want to highlight where we stand. First, we have to emphasize the idea that not all iliofemoral DVT are the same, which means that we still see in our practice some iliofemoral DVT patients who have almost no symptoms and there is no edema in their legs, while other patients will have phlegmasia. So we cannot treat all the patients the same just because they have iliofemoral DVT. We are treating a patient, not a scan. So we don't exactly understand how deep veins are behaving following DVT. And we can build up our decision to give any patient thrombolysis depending only and solely on the site of the DVT. More symptomatic patients will definitely benefit more from asymptomatic patients or less symptomatic patients. As we have mentioned, the key success should be to remove as much as we can of the thrombus burden in iliofemoral segment. To assess if we have achieved this goal intra-procedure, venogram is not always enough to assess remaining thrombus load. So we have to use IVUS if it's available. And we cannot achieve this goal without knowing accurately the thrombus age. And thrombus age doesn't depend only on the patient's symptoms, but better depending on the radiological finding in the duplex and the MRV preferably. So if the patient has an indication to be stented, we should use a dedicated venous stent. And for femoropopliteal DVT, there is a consensus, except in very, very limited cases, that we have to use only conventional treatment in the form of anticoagulation, compression therapy, and early mobilization. So who would I use thrombolysis for? Either catheter-directed thrombolysis or pharmacomechanical thrombolysis. I will recommend to use it in young, mobile, active patients with severe initial symptoms and signs of DVT and or high risk of future DVT who has an iliofemoral DVT proven clinically and radiologically to be an acute event started less than 21 days ago. How would we treat them? Cross-sectional image pre-procedure is mandatory. Consider distal axis. Consider pharmacomechanical more than pharmacological to decrease the complication of the thrombolytic agent. And IVUS is available, is highly recommended, and stent if indicated. Thank you very much.